All right, I'm Amish Dave, as Jerry said. I'm one of the EPs here, and I'm going to talk about this topic. This is a little bit of a broad topic, so it's hard to get deep in this type of topic. A disclosure, I'm a consultant for some St. Jude studies. I'm going to briefly break this down into a smorgasbord of topics. So cardiac arrest prevention review, CRT, new things over the last year, some new things in stroke prevention that probably everyone's heard a little bit about, and new developments a little bit in VT ablation. So ICDs, probably everyone's seen some version of this slide. This is just a version I've modified. So we know from landmark studies from decades ago that ICDs can save lives. The number needed to treat is what I'm displaying on this slide. And for most of those ICD trials, to save one life, the number needed to treat ranged from something like 3 to 14, depending on the population, over anywhere from 2 to 5 years or so. And it compares favorably, of course, to various drug trials for things like captopril, beta blockers, statins, and amiodarone. This year, I wanted to modify this slide, so I've added Entresto. Entresto has a number needed to treat of 36 from the Paradigm HF trial to save one life in 2.25 years. And the Made It CRT trial kind of serves as a reminder that if you take patients, and these are patients who have an ICD indication but also have a left bundle branch block, then if you give them a BiV device as compared to an ICD device, you have an incremental benefit. The number needed to treat is about 9 to save one additional life in 7 years. There are some open questions. There's room for more clinical trials. This was an article in Jack Heart Failure from just a few months ago, and the editorial actually asked an interesting question, which is, should there be a Made It VAD trial? The review was a meta-analysis of patients in LVAD trials and the role of ICDs. And they showed that there was a mortality benefit to having an ICD in these patients, but the subgroup analysis showed that in the more modern generation of LVADs with continuous flow, the mortality benefit was no longer significant. And so this is really still an open question. We've all probably seen patients with LVAD who come in after hours of VF, and they don't look good, but they're not dead. So there's questions in terms of how to best program ICDs when we put them in VAD patients, or when an ICD patient gets a VAD, and really who's the best patient for it. Should it be stratified based on RV function or things like that? I'm going to switch gears to talk about CRT. In the last year and a half or so, new development really that's come about has been the development of the delivery of multi-site pacing to more patients outside of clinical trials. So in traditional cardiac resynchronization therapy, we know that there's usually one left ventricular and one right ventricular pacing site. In small studies, people had found both acute hemodynamic benefit with PV loops and things like that, as well as echocardiographic and clinical parameters when an additional LV site was added, typically with another LV lead and an adapter. But that involves extending the procedure time and potentially complications due to additional leads, and not every patient was going to be able to get that done. The new development is to take a sort of a standard, clinically approved for many years, quadripolar LV pacing lead, and normally when these leads are put in, you can tell there's 4 electrodes on these leads. They reduce the complication rate for CRT because you can avoid phrenic nerve pacing more easily. You can achieve a better threshold. You have a lot more flexibility and a lot more options. But normally, you're pacing from one of these electrodes. One of them serves as a cathode. If you modify the generator so that you can pace from more than one of these sites simultaneously, you can pace from this site, and the RV lead, and achieve multi-point pacing. And in the clinical trials, right now there's one randomized double-blind multi-center clinical trial that was the results of which were given at the Heart Rhythm Society meeting in 2016. That trial involved about 506 patients, and that was the IDE study for this device. The results were promising. I'll show them, and it led to the approval of the device. The more CRT trial will be completed in March 2019. It's already completed enrollment of about 2,000 patients and will provide better long-term data. Right now we don't have that. But what we do have is from the MPP IDD trial, the CRT responder rate seems to have gone up quite a bit. So traditionally in most studies we found that the percentage of non-responders to cardiac resynchronization therapy has ranged from 30 to 40%. It's been disappointingly refractory to all of our attempts to understand and better predict who's going to respond and who's not going to respond. In this trial, which admittedly was 500 patients and not thousands, the patients who got this MPP device, multi-point pacing device, and a quadrupolar lead, who were able to be programmed such that the electrodes that were made into the cathodes were more than 3 centimeters apart, the response rate was 87%. And even more interestingly, every patient in this trial served as their own control, and so the patients were given several months without that feature enabled, and then several months with that feature enabled in a double-blind fashion. And the 8 patients in this subgroup who had this level of separation, who did not respond to regular bi-V pacing, each of them became a responder when multi-point pacing was enabled. We've had smaller clinical trials and observational studies looking at the hemodynamic benefits from this system and this device, and they've shown statistically significant improvements in the ejection fraction and reduction in LV size. So this is an exciting development that may be able to help a lot of CRT non-responders. Many of these patients actually have quadrupolar pacing leads already in them, and all it might take would be to change the generator if they have good capture characteristics. Shifting gears again, this is an interesting study that just came out in December, and it serves as a nice reminder to a point that I run into very often, so I wanted to include this. Basically, in this study, there were about 823 patients, all an observational study, retrospective from the Cleveland Clinic. And then what they did was they went back and looked at everybody who got a non-CRT pacemaker device, who and asked the question, who develops RV pacing-induced cardiomyopathy, and what's the prevalence, and what are the predictors? What they found was that the incidence was about 12%. 101 of these 823 patients went on to develop a cardiomyopathy. And the predictors of that, so that's, you can think of that almost as a number needed to harm by giving a dual chamber device or a single chamber device instead of a CRT pacemaker. This is something like 9 or 10. The predictors of that were the baseline ejection fraction. For every 1% that was reduced from normal, that was an increment of risk for developing a worsening of ejection fraction. And whether the RV pacing percentage was over 20%. So you don't have to have complete heart block and 100% RV pacing to develop cardiomyopathy. And actually, the hazard ratio for those patients who were RV paced over 20%, these are people, most of them had normal ejection fractions, was almost 7, so not small. So in the patients who did have pacing-induced cardiomyopathy, many of them were undertreated. Not all of them were upgraded, but those who were upgraded to CRT, the response rate to cardiac resynchronization was 84%. So, and the degree of improvement in ejection fraction was about 18%. So, just please don't send patients who have a lot of RV pacing and dual chamber pacemaker for an LVAD without at least considering cardiac resynchronization therapy. Now, left atrial appendage thrombi in stroke. Basically, this is something that all cardiologists deal with. All cardiologists deal with patients who have AFib and A-flutter and develop strokes. But the incidence is much higher in the population of your patients and heart failure patients. This is a chest pain-inducing thrombus. The Watchman device is the newest development, it's the newest approved development in treating stroke risk. And in general, what it involves is an intravascularly delivered via the femoral vein device that plugs up that left atrial appendage. It's done basically through one sheath. The procedure takes about an hour. Patients go home the next day. The device has a stent-like strut system with some hooks to keep it in the appendage and a membrane that's designed to endothelialize after 6 weeks, as you can see over here. And the clinical trial data for this study, for this device, was extensive and controversial and confusingly organized. But the two randomized clinical trials were the PROTECT AF trial and then, as the FDA wanted more data, the PREVAIL trial. And these studies randomized between them 1,261 patients to either, in 2-to-1 fashion, the device or Coumadin. And there were some continued access registries after each of these two trials that each of them enrolled more than 500 additional patients, all of them getting the Watchman, so not randomized. The totality of the data was analyzed and published by Dr. Holmes and in Jack, and the net result led to approval of the device with conditions including a registry and things like that. What we found was that the all-cause, all stroke or systemic embolization rate was non-inferior for the device compared to Coumadin, and that led to approval. But the actual ischemic stroke risk was probably was actually a little bit higher in this device than in the warfarin treated patients. It was more than overcome by the very significant reduction in hemorrhagic stroke, leading to the results I just gave. So it actually did have a significant reduction in cardiovascular or unexplained death. There was a trend, but that wasn't significant in the totality of the data for a reduction in all-cause death. And so that is something that probably more and more of your patients will be getting. Anyone who is stable on warfarin or a NOAC is probably fine to stay on it for now, but those patients were probably not great candidates for continued long-term anticoagulation. Probably more and more of them should be getting some alternative option like that. VT ablation is something that probably many of you have had patients who may or may not have gotten it or needed it or whatnot. The clinical trial, the randomized clinical trial evidence base for VT ablation is on this slide. There have been other observational studies, but the randomized trials include these four, of which 3 were completed. SMASH VT was published in 2007 and enrolled 128 patients followed for 2 years. And ablation reduced the incidence of VT or ICD therapies by a significant amount. The hazard ratio is 0.35. VTAC was published in 2010 and had similar results, a reduction in VT or ICD shocks. And these trials were for basically VT ablation versus antiarrhythmic drugs in SMASH VT and VT ablation at the time of ICD implant versus ICD implant without VT ablation over here. Calypso was canceled, and it basically they were only able to enroll 27 patients out of 243. You can see from the numbers over here that it's very difficult to enroll patients for these trials, and right now we're involved in various VT ablation trials, as are many centers around the country. We're really hoping to increase enrollment. Vanish, it was just published this last year, and actually it was just announced. The results were given at this year's heart Rhythm Symposium. The study compared VT ablation on patients who basically had already been treated with antiarrhythmic drugs for VT versus escalation of the antiarrhythmic drugs to very high doses of amiodarone or additional of high doses of mixoltine or sotalol 2-wit. And 259 patients were followed for 28 months, and again, VT ablation was able to reduce the incidence of VT storm or ICD shocks or ATP therapies with a hazard ratio of about 0.72, and that was the largest trial that's been completed. So the issues with this are none of these were adequately powered to make a statement about mortality. None of these studies enrolled patients with non-ischemic cardiomyopathy. Every one of them enrolled patients with only ischemic cardiomyopathy. None of them have really looked at the use of things like the Impella device or other percutaneous LVAD support systems that nowadays we often use during VT ablation to try to allow us to leave the patient in VT a little bit longer and map it better. And none of them have compared different approaches to VT ablation. There are different strategies to VT ablation for different operators, different centers, and different patients. So with that said, I'm going to complete my talk on time and finish.